Welcome to today's webinar entitled Patient Preferences for Non-Small Cell Lung Cancer Treatment Options. Our presenters will be Dr. Isabelle Huys, Professor, Department of Pharmaceutical Sciences at Leuven University, and one of the academic co-leads for this case study. Dr. Serena Oliveri, Senior Researcher at the European Institute of Oncology in Milan, Italy, and also the other academic co-lead. Dr. Rosanne Janssens, Postdoctoral Researcher at the University of Leuven. And Dr. Meredith Smith, myself, Head of Risk Management at Alexion AstraZeneca Rare Disease, and the industry lead for this study. Next slide, please. Here are our disclaimers. Just think want to note that this presentation reflects the views of the presenters and not the views of Prefer, IMI, the European Union, or EFPIA. Next slide, please. Our presentation will be organized as follows. The background and aims of the case study will be presented by Dr. Huys and Dr. Oliveri. The qualitative study and its results will be presented by Dr. Janssens. I will provide an overview of the educational tools, and then Dr. Oliveri will describe the quantitative study and results, and then we will have a transition to a Q&A session. Now I'll turn it over to Dr. Huys.
Thanks a lot for this introduction towards the case study in lung cancer that we will present today to you. Next. This case study is actually a case study which has been performed in the project Prefer of the Innovative Medicines Agency. Oh, yeah. It is a collaboration between different non-profit and profit partners, namely the industrial partners and non-profit partners being academic institutions, patient organizations, and even a health technology agency. And the aim of this huge project is to establish recommendations in the context of the methodologies used to measure patient preferences and also use the results of patient preference studies in order to support the development of guidelines in this context by, for instance, the industry, by the regulatory agencies such as the European Medicines Agency, by HTA bodies and payers. That is one outcome, recommendations on how and when to assess and include patient preferences to inform medical product decision-making. Another outcome of Prefer is to provide training in this context. And that is what this series of webinars is about, to train the stakeholders in this field. We will also produce organizational guidelines that are useful to conduct patient preference studies and are in the process for EMA-UNETA qualification, where we are very happy that for the moment we have a preliminary positive opinion from the European Medicines Agency in terms of qualification of the framework for patient preference studies that we have created within Prefer. Next. Prefer started already in 2016 by first identifying and assessing multiple methods suitable to measure patient preferences. Qualitative methods, so exploratory methods, and also quantitative methods. And these methods have been further used in different case studies, for which the lung cancer case studies is one case study. There are several other case studies conducted in IMI Prefer as well. And based on these case studies, we have also been drafting recommendations which will be final at the end of Prefer, which is to be end of March 2022. Next. But what are patient preferences actually? And for that, I refer to the definition that the FDA has been providing to us and which we have been following during our project. Namely, it is a qualitative or quantitative assessment of the relative desirability or acceptability to patients of different alternatives or choices amongst outcomes or attributes that differ amongst alternative health interventions. This is actually a difficult definition, but what it is about is actually to find out more what patients find important about characteristics related to treatment and diseases, and how important that they find these. An important word in this definition is the term attributes. You can click on it, Karel, attributes. And attributes refers to, next, either benefits related to treatments, next, risks or inconveniences which can be linked to different treatments, and next, potentially also uncertainties that are related to treatments, especially when these treatments are new, innovative, and uncertain. Next, what patient preferences also can provide to us is a lot of other type of information, next, that is relevant for patients and for the whole community. Next, these patient preferences can be studied in patient preference studies. And for that, we have in Prefer developed a full framework for that, incorporating the use of methodologies, qualitative methodologies and quantitative methodologies, namely interviews and focus group discussions next to service-based methods. And the full framework consists of different steps, starting from design phase of a patient preference study, going over to the conduct of a patient preference study, and afterwards, very important to communicate about the results of patient preference studies to those who need to have these results in decision making. And along all that, the organization of a patient preference study. And this has been implemented in one particular patient preference study, namely in the lung cancer case study, which will be presented today. And for that, it is also very important to learn first more about the background of the disease itself, in this case, lung cancer. And I give the word to my colleague, Serena Oliveri.
Thank you very much, Isabelle. So I will spend some few words to describe the disease and to introduce the preference-sensitive situation for which lung cancer case study was conducted. So lung cancer is an uncontrolled cell growth into the lung tissues. In particular, the non-small cell lung cancer is the most common form of lung cancer, and also the deadliest one. Indeed, only 21.7% of patients diagnosed with lung cancer, with non-small cell lung cancer, survive 5 years after the diagnosis. Based on the level of spreadness of cancer into the lungs, we can distinguish stages, different stages. Early stages 1 and 2 imply that cancer is locally circumscribed in lungs, in one lung. Later stages, instead, 3 and 4, in later stages, cancer has already spread throughout lungs, but not in the rest of the body in case of stage 3, or has begun to spread into different parts of the body, such as other organs, in stage 4. In a condition named metastatic condition. Next, please. Of course, for the lung cancer, many different treatment options exist. The chemotherapy and the targeted radiotherapy are the traditional ones. Instead, a new promising treatment called immunotherapy stimulates the patient's immune system to fight against cancer cells. Different combination of therapies are possible to fight against cancer. But each of these options imply a sort of balancing of benefits and risks. Benefits in terms of increase in life expectancy, or improvement of symptoms, but also risks in terms of higher toxicity and higher probability of side effects. Next, please. In particular, in 2019, the EMA approved a combination of immunotherapy and chemotherapy for the first-line treatment of metastatic non-small cell lung cancer. In some patients that present a high expression of this particular protein, named the PD-L1, can also choose between two options, immunotherapy alone or immunotherapy plus chemotherapy. The combination of immunotherapy and chemotherapy, of course, is more efficient, has higher efficacy in fighting cancer, but it implies also more toxicity and more side effects. So there is an uncertainty surrounding patients' decision-making, the decision that patients have to, the decision-making process that patients have to make together with their physicians. Uncertainty related to the level of efficacy of the therapies, but also the level of patients' tolerance for a higher toxicity. But in particular, what is unclear is what is exactly relevant to the patients when they have to choose for a therapy. So what matters most to lung cancer patients when they have to choose among different options and different probabilities of benefits and risks? Thank you very much, and I leave the speech to my colleague Rosanne.
Hello, everyone, and thanks a lot, Serena, Isabelle, and Meredith for already nice introductions. So here I will present today on the findings and the methodology that we applied in the first portion of the patient preference study that we conducted among advanced lung cancer patients. Next. So here you can see, first of all, why and what type of information we tried to investigate or to yield via our qualitative study. So the arrow represents the entire case study that we performed, where we started our research, or where we found it very important to start our research with a qualitative study starting bottom up from the patient population. So we considered a qualitative study component very relevant to include as a preliminary step in order to ensure that the next phase, so the survey that we developed based upon these results from our first qualitative study, would be patient-centric. So we wanted to first get insights into what matters most to patients via sitting together with them in a qualitative study context, to understand which components are now most relevant, components or attributes as first explained by Isabelle, and which we should therefore further investigate, include in the quantitative survey. So we found it important to yield both qualitative data and quantitative data on patient preferences. So first of all, qualitative data. What is qualitative data? It is actually non-quantitative data or non-numerical data that gives insight into how patients think and feel with respect to their health and treatment options. So it gives insights into their opinions, what matters, as here reflected on the right side in the first part, what matters to them, what type of outcomes, for example, treatment outcomes, do they find important, why, what type of side effects do they find burdensome, how do they experience these side effects, how do they may affect their daily life, and understand why and in what manner. Or also perhaps, as reflected upon earlier, what are uncertainties that these patients are confronted with? What are the types of uncertainties? What would help them in order to proceed with the therapy or not? So what is actually needed from a patient point of view with respect to their health and treatment? So this is what we try to investigate in this qualitative first study phase. The next, so these elements, the range of aspects that patients would highlight in this patient focus group discussion, we could then incorporate in the next phase, the survey, where we included two types of preference methodologies, namely discrete choice experiment and swing weighting. And this survey will be further explained in the presentation by Serena Oliveri. So whereas here in the qualitative study phase, we were interested in understanding the range of elements that matters to patients and why, but the how much we also try to already elicit a little bit in this qualitative study component by including ranking exercises in which patients were triggered to reflect on what now do they find the most important of different characteristics of therapies. So whereas this was the major focus of the survey, in the qualitative study, we also got some preliminary insights into that. Thirdly, we could already also learn the types of trade-offs that patients were willing or not willing to accept. We learned about, so patients made statements like when they would stop or when they would consider stopping a treatment, what are the aspects then when they would be not willing anymore to take on a certain side effects or so. So we also got some insights into that already in the qualitative study. And with respect to patient heterogeneity, or the heterogeneity that we can find in the study results based on patients' characteristics, this was also a major focus of the survey. However, in the qualitative study phase, we also already noticed that there were different opinions expressed depending on the specific treatment and disease context of particular patients. For example, patients who had already experienced some side effects would related to either chemo or immunotherapy would reflect on these different side effects and would place even a higher weight or so in their opinions, in their qualitative opinions on this during the discussions. Next.
So here you see what we aim to do with this qualitative study. So to define or to understand and then define the factors or attributes that matter most to patients, understand also why. And these are both related to the disease and the treatment. So for example, symptoms they find detrimental, side effects that impact or would impact their choices at a later stage. Next slide, please. Our qualitative study consisted of 4 different phases, which you can here see on the slides, where the qualitative focus group discussions were informed by a literature review. We did a literature review to inform the questions that would be asked in the focus group discussions, to understand, first of all, what are previously conducted patient preference studies in the area of lung cancer. So can we learn from that already a little bit about what would be potential attributes of relevance that we could include into the survey? We also investigated the clinical trial database with respect to the clinical trials that are both ongoing or concluded in the most recent years regarding lung cancer therapies. So to understand what are the therapies that are in development, and also more importantly, what are the side effects and the treatment outcomes being reported from those clinical trials, and this to ensure that the attributes that we develop are reflecting, in fact, the reality. So reflecting what will come or might come to the market, as well as what are therapies that are currently already being administered to patients. And this last element, so identifying what has been already or is already being administered to patients in the reality, is what we also aim to investigate via looking at the websites from the EMA. So looking at the treatments who have already been approved for this particular disease population, what are the benefits, what are the risks and the uncertainties related to the therapies that have been approved, and also for the same aim is to ensure that the attributes that we identify reflect those elements related to therapies that are that have been approved. So we performed then in phase 2, we performed 4 different focus group discussions in Belgium and Italy. So we included 2 countries to increase the heterogeneity of the patient sample with respect to variables that could influence their views towards what matters most to them. So with respect to the disease treatment history, for example. And in the first first focus group discussions, we wanted to get a view on the range of elements, the range of attributes that would define patients' choices, and understand also why. So that is really also the added value here, is that we wanted to understand also from patient point of view, if they find a symptom or a side effect very burdensome. Why is this so? What is the final, how do patients describe this? And then in a subsequent phase, in phase 3, from this broader range of elements that we identified in the second phase, we wanted to understand what matters most from all of these things. So we included a certain technique, which is called a nominal group technique, where patients were asked to reflect on what of all of these different things is now most important. The nominal group technique is a certain ranking exercise. So next is a certain ranking exercise, which triggers the participants to think of a range of aspects, what is now most important to them. And then in the final phase, the fourth phase, it was also really important, we held several discussions. From those patient focus group discussions, we held several iterations and discussions involving also clinicians, involving experts with a patient preference study design and conduct, to understand how this qualitative information can be then translated into attributes, and their descriptions and the levels. And this was also a very important step and a difficult step to perform, to come up with the final formulation as to how we will formulate the attributes into the eventual survey. So next. So here a little bit more about the sample that we included. What is important from this slide is that we try to include a heterogeneous patient population with respect to characteristic that may influence their views expressed on what matters most to them. And this is because we wanted to get a broad view on the elements that matter most to them. So, for example, we wanted to include patients who were already in treatment, because we considered that their experience with the treatment, so if they have experienced already immunotherapy and chemotherapy, this experience is important to find out what are now side effects, for example, of immunotherapy or treatment outcomes that these experienced patients have already gotten insight into. Regarding exclusion criteria, we wanted, of course, that these patients would be able to participate into the study. So this meant in our case that they would be able to talk about their feelings. So also understand what we wanted to have at the qualitative study, so that they understand also what is the meaning of this study. And this was all evaluated by the clinicians, so where they also evaluated whether they could contribute to the study, as these type of patients are often very fragile as from their disease. So of course we would want that these patients are able to, and would not want to overburden them with something that at that point in their disease would be too burdensome for them. So we had clinicians evaluate these different exclusion criteria and include those patients meeting them. We selected a final sample of 36 patients in Belgium and Italy. Next, please. So here on the results, you see a big cloud. What we identified, what matters now to these patients, are a range of elements. So what matters to patients can be divided in, let's say, positive elements and more negative elements. And on the positive side, what these patients reported is that they want to increase their life expectancy. So they want therapies to increase the additional years that they have for them. But another big theme was that they also want to, as much as possible, maintain their daily functioning as much as possible as before they were ill. So this means that every symptom or side effect that limits them in performing daily activities, they found detrimental. For example, there was a lot of reporting on the pain that these patients experience, both due to the cancer as well as the therapies, and this is reflected here also on the slide as the fatigue that these patients reported, so the extreme tiredness, which also hampers them in performing their daily activities. A final theme, what we revealed were the uncertainties regarding their future health state. So patients were uncertain about the long-term efficacy, let's say, of this therapy. So how long will this therapy be working? They were afraid of a next scan or a next lab reporting where that would come out negative, let's say, in the sense that the therapy is not working. They were also uncertain about side effects that might pop up in the future, or side effects that they were experiencing now, that then they were uncertain how long will this side effect last still. So this was a broader range that we included into the next step. Next slide, please. Where we had, as I already described, a nominal group technique. It's a type of a ranking exercise where patients were asked to reflect on this different range of elements to come up with their views on what is now most important. So these elements we would take further into the survey. And this list of final elements was also informed in a final stage by several discussions and iterations to reformulate and improve the way we describe these attributes towards patients in the survey. Next slide, please. And here I will not go over the different attributes, their definitions and their levels, but I will maybe take out one here, is a chance of being extremely tired, where we first thought, okay, we will take fatigue, as is described often in the clinical trial reporting or in more clinical oriented texts. Where we really had several iterations with the physicians, from the patient discussions, how do they describe this? And they just mentioned, okay, being extremely tired. And so this is how we then also define these attributes in the survey text. Next slide, please. So as a key takeaways, we have that we found it very important to use a qualitative data component into our study design to gain insight into what is the range of elements, so the breadth, but also why, the depth, understand why of elements that matter most. And that is why this is complementary information to the quantitative survey design, where we would want to quantify what matters most to patients. So this data helped us understand why certain elements are important and reach a broad range of information regarding preferences that influence or would influence their choices. So therefore, we would say that the learning from this study is that a qualitative data component helps ensure that the attributes and levels and the descriptions should be informed by such a qualitative data component that is further investigated in the quantitative survey.
Thank you. Next slide, please. Here's my disclaimer. Next slide, please. So why use an educational tool in the context of a patient preference study? Well, there are at least two compelling reasons for doing so. The first has to do with maximizing the validity of the data being collected. Accurate preference elicitation depends not only on patient understanding of the content and the context of the study, but some information about the disease state, and understanding of the attributes and the specific attribute levels, and an understanding of not only the choice tasks, but how to do them. A second important reason to include an educational tool is to reduce the likelihood that patients are confused or misunderstand a particular question, which in turn could cause measurement error. Next slide, please. An element in selecting an educational tool concerns the modality. To date, most patient preference studies have used printed materials as a way to educate participants, but there's increasing body of evidence to suggest that digital approaches can offer some advantages in terms of improving participant engagement and motivation through a variety of different design features such as interactivity. And in doing so, can assist in learner mastery of the preference construction tasks. Next slide, please. So in the lung cancer case study, we decided to develop a digital tool, an educational video, that was guided by a framework based on empirical research and consensus recommendations from experts in the digital health research field. The educational module consisted of educational video consisted of 3 separate modules. The first focused on explaining the disease state and the 5 treatment attributes and their associated levels. Modules 2 and 3 instructed participants regarding how to articulate their preferences for treatments. Module 2 was focused on the discrete choice experiment, and module 3 on the swing weighting experiment. We did pre-test the video in a small group, 5 patients, and then there were some modifications and revisions made as a result of that pre-testing. Next slide, please. Here are some of the key features of our video. These included color graphics, interactive navigation. There was a voiceover, a variety of different icons were used, and then the content adhered to plain language principles that were written at an intermediate reading level. For those in the US, that would be approximately 6th to 8th grade reading level. And then some visualizations to demonstrate key learning points, as well as to enable patients to practice completing choice tasks. And to do that, we used a fictitious medication, a cold medicine, as an example. Next slide, please. Here's just a screenshot showing what the attributes, how they were displayed in the video. This is the Italian version. Next slide, please. And here's how the discrete choice experiment and swing weighting instructions were laid out in the video. On the left, this is a discrete choice, and on the right, the swing weighting. This is what participants would see. Next slide, please. At the end of the questionnaire, we had several questions about the participants' experience with the educational tool. The first of them concerned how helpful they found the tool to be. Next. And we found that the majority of participants found the tools to be either moderately to very helpful in assisting them in completing the choice tasks. There's slight difference in terms of country of residence. Italians reported finding the tool to be a bit more helpful for both discrete choice and swing weighting tasks as compared to their Belgian counterparts. Next slide, please. Thank you. And the second question concerned how easy did they find the tasks themselves. And in this case, again, we found that the majority of respondents across both countries found the 2 tasks to be between easy to very easy to both understand, to both answer and understand. Next slide, please. So by way of conclusions, we found that we were able to demonstrate real value in including an educational video in this patient preference study. It had enhanced multimedia features that the majority of participants found helpful. and express their satisfaction with using. I think probably a major strength is that this development of this video was based on a theory-driven and evidence-based approach, this EduGrid, which is our framework. But one caveat is important to note is that digital approaches such as developing a video do require longer development time and are more expensive than print-based tools. Next slide, please. And then finally, some comments about our limitations. We did not have a comparison arm, so we're not able to observe whether the use of our video-based educational tool was resulted in a superior comprehension on the part of participants who were assigned to that, exposed to that. And we did not assess comprehension per se. In fact, there's a need for further standardization and consensus regarding how comprehensive should be defined and assessed in the context of a patient preference study. And there's scope for further research on whether a framework such as the one we used indeed meet their intended outcomes. Next slide, please. So just by way of a few key takeaways, we know that patient preference construction can be influenced by the decision context, and that people construct those preferences as they go along in the course of performing the decision tasks. Factors that influence that preference construction include not only the decision context, but the framing of the choice task and the way relevant information is presented to them. And educational materials then play a key role in helping ensure that patients and participants really understand that decision context, really understand the choices that they're presented with, and understand what to do. In other words, how to perform the preference tasks.
Okay, so the main aim of the quantitative study was to assess preferences for lung cancer treatment attributes by calculating two main indexes, the maximum acceptable risk and the minimum acceptable benefit. The first index, maximum acceptable risk, basically describes the maximum level of risk that the patient is willing to accept in terms of toxicity or side effects in exchange for an expected benefit. In our case, we can say survival. The minimum acceptable benefit is instead referred to the minimum benefit that the patient would expect for a switch from a therapy to another that implies more toxicity or more side effects. The other aim was to investigate variables that might explain preference heterogeneity, such as psychological constructs, demographic variables, clinical variables. And finally, assess the usefulness of the educational tools, as Meredith already presented in the previous presentation. So the quantitative study was conducted in two different cancer hospitals in two different countries, Italy and Belgium. And we enrolled a total number of 307 non-small cell lung cancer patients from stage 1 to stage 4. We invited them to fill in an online survey. So the survey was composed by questionnaires, by educational tools, and two different choice tasks, the discrete choice experiment and the swing weighting. Next slide, please. Here I would like to introduce you the structure of our survey. So we started with some demographic and clinical questions, of course, to know the overall current situation of patients, followed by the educational tool introducing the attributes and one educational tool describing how to perform the first choice task. And then followed by one of the two choice tasks. Consider that we randomly proposed to the patients the two different choice tasks with a crossover design ABBA, in a way that first patients, for example, had to perform the DCE followed by the swing weighting, but other patients performed the swing weighting then followed by the discrete choice experiment. After the first choice task, some feedback questions were proposed, questionnaires related to the psychological constructs, health literacy, and health locus of control, then followed by the second choice task and a final list of feedback questions. Next slide, please. Okay, this is again the picture representing how we displayed the survey to the patients, the educational tools, the two different choice tasks, and the feedback questions in the form of the Likert scale. Next, please. Our sample was composed by an equal number of males and females, and their age ranged from 55 to 64 years old, and from 65 to 74 years old. I would say fully representative of what has already been observed in the clinical practice and in literature, since lung cancer is mainly diagnosed when people are 65, from 65 to 70, we would say. This happens because the main symptoms of lung cancer are cough or shortness of breath, and these symptoms are common to many other diseases. For this reason, the most of the people are not checked for lung cancer, since the cancer is already spread in lungs and also maybe in other parts of the body. I would focus on other two socio-demographic results of our sample. The fact that we had almost an equal number of people that were at stage 1 and 2, and people at a later stage of cancer, 3 and 4, in a way that we were able to compare preferences depending on the level of cancer stages. And also depending on the lines of treatment. We had almost the equal number of people that never underwent lines of treatment different from surgery, for example, and people that had extensive experience with other different kind of treatments and underwent from 1 to more than 3 lines of treatments. Next, please. Some key findings. Concerning the overall preferences, we found that all patients preferred survival over any other kind of aspects, any other kind of attributes. And in terms of trade-offs, patients were willing to accept a substantial increase in the chance of developing side effects in exchange for the slightest chance of surviving, at least 5 years after the diagnosis. Just to make an example, our patients preferred for a 1% point increase in the probability of surviving. They preferred high probabilities, like 8.5 increase in the probability of suffering for severe side effects such as long-lasting skin problems or fatigue. About the MAB instead, the patients expected to obtain a considerable increase in the chance of survival, to accept a switch from a therapy to another that had worsening conditions in terms of mode of administration and air loss. But in our study, we obtained that these were the less important aspect for them. Next slide, please. This is a graph representing what I said, I described it before. As you can see, the column related to the survival attribute is the most important one for all the participants, followed by all the other aspects related to the side effects and to the mode of administration. Concerning preference variability, we found that 2 classes of patients explained variability in preferences. Please, next. Class 1, that was composed by people with high health literacy and high education level. Next. And class 2, that was mainly composed by elderly patients and patients with high internal and chance loss of control. This means that preference heterogeneity in our study were explained by age, literacy, and loss of control, basically. Next slide. We didn't find heterogeneity instead for country, cancer stage, or lines of treatment, having children and quality of life. I would like to focus on the results related to cancer stage or lines of treatment. Indeed, we expected to find variability in preferences due to the cancer stage, early stages versus later stages, and lines of treatment, because we expected that people that already had an excessive experience with the treatments, or people that are at a later stage of cancer, would prefer survival more than people at early stages. Why I say that? Because usually for the early stages, for stages 1 and 2, surgery is possible to fight cancer. And apart adjuvant chemotherapy, these people have a different experience in terms of life expectancy and prognosis compared to people diagnosed at a later stage for lung cancer. Also, the clinical pathway is different, but we didn't find heterogeneity. So many hypotheses are possible in this case. And one of these is that some massive campaigns about the mortality, the level of mortality and poor prognosis of this cancer affected the perception of the seriousness of this disease. And we obtained that people, when they are diagnosed for lung cancer, we can hypothesize that when people are diagnosed with lung cancer, independently by the cancer stage, are worried about their life expectancy and survival. Next slide, please. Okay, some key conclusions. So lung cancer patients are so physically and psychologically fragile that their main concern is to increase life expectancy when they have to choose for a therapy. But another hypothesis that we did is that it is also important the way we present to them the different attributes, and in particular the way we presented to them the attribute survival. We presented it using a positive framing, giving less importance to the severity of the side effects. This maybe created a sort of anchoring effect. So when they had to choose between different scenarios and therapies, patients anchored their attention to what was most important to them, survival. Preferences were found to vary based on age, education, and health literacy. And in particular, we obtained that patients that aged 65 and over gave higher value to the side effects compared to people with high literacy and high education. This may be happening because elder people usually are give more importance to their daily functioning and to their quality of life, and are more worried about the way side effects can affect their daily functioning. Younger patients instead, and patients with a higher level of literacy and education, had a different preference related to the mode of administration. They preferred to take a pill versus having an infusion compared to the rest of the participants. And this may be interpretable in terms of the fact that they belong to the working class Younger patients belong to the working class, and going to an hospital for 24 hours of flu infusion takes time from family and work and many other activities. Next slide, please. Some key learnings by performing our study was that we had, for us, it was really challenging to translate the open-ended results that we obtained in the qualitative phase, in the qualitative, using the qualitative methods, into the discrete attributes and attributes levels that we used in the quantitative study. Because the risk is to lose a lot of information, important information that instead can arise in an open discussion with the patients. The other aspect, important aspect, is that we underestimated the importance to involve caregivers and physicians in engaging patients to participate to our study. Even considering the current pandemic situation, we had to perform our study using an online survey, and caregivers were really important to raise the interest of lung cancer patients that are already, as I said before, fragile and vulnerable and worry about their life, to highlight the importance to participate to such kind of studies. Next slide, please. Okay, some instead strengths of our study are, for example, a robust design, the fact that we used two different preference elicitation tasks to compare results between two tasks, and comparison of two separate countries in order to control possible differences, to cultural differences, and the participant feedbacks. Next slide, please. I would like to thank and acknowledge all the people that participated to our study. Next slide. And this is a list of currently available publication that we have for lung cancer case study. We have currently in preparation the paper related to the publication related to the main clinical results of the quantitative study.